Hello? Oh, this is so loud. Can we? It's okay? I think lower. This is so loud. Okay. If your eardrum's gone, it's done a mistake. It's okay or it's too much? Too much. Okay, okay. I'll try to be cool. Okay, so my name is Mahmoud, and as Uthai mentioned, I'm representing a company called Chemedics. We have started working with Brera, I would say, end of 2022, beginning of 23. So it's almost 1 year and a half. We started with Kuwait and Egypt, and now we're doing Dubai and Saudi, but still Saudi still need the registration, which is expected to be in September. So I believe together we can really, let's say, discover that missing 1% from Attilio presentation. And I'm sure that really if we have been successful to create the momentum, the global momentum, because now the patient asked Dr. Google. So let's say when a good like Jovena, he heard about Jovena from Instagram, from blah, 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 from UK, from wherever, Jovena. If he find only, let's say, news or feedback from UK only, or from US only, or from the Gulf or the Middle East only, he will have that feeling that it's most likely a local treatment is not so popular, and this is exactly what BTL trying to do. They are spending a lot on marketing in order to create a global momentum. In fact, we have started in Kuwait. We have started to receive some patients asking from IMSCAL from the States with the claim of the state, which has never been true in our region. So even if that was like a false claim or a mismarketing or a negative marketing, but we still got some leads from the States in Kuwait, because we are selling some of the BTL devices as well. So this actually was the idea behind this opportunity that Attilio and Uthai would say, why we don't all together create the same message, same focus, and we create the momentum that will lead the success of all countries. So, yep, today I would not say that we have discovered a new thing or we are going to share a new experience with you. It's exactly the same what you are doing, but maybe it's in a different way. So this is why we need really to dig a little bit deep into anatomy, into science, in order to let the doctor respect any salesperson when he's come. If we position ourselves as a salesperson or a sales rep, the door will be our next step. But if we position ourselves as a solution provider, this is the only way that we gain the trust and respect of the doctors. So we are not a salesperson, we are a solution provider. And in order to be so, we have to understand the problem. And the more deep, in depth we understand the problem, the better we can express the solution, if it's any of there. So this is why let's start. Well, I would appreciate if you can go for the facial layers anatomy, but if any of the expression is not clear, information is missing, please ask. At the end, we are all in the same boat, and we have really to deliver. So here I mean facial layers, not skin. So we are not going to discuss skin anatomy, it's so boring, but the facial layers anatomy, and there's a big difference. And then we have a new dimension of facial aging. It's a new consideration. Actually, before 2016 and after 2016, that year was a totally shift in the mindset of the doctors, because they have discovered a new era in the anatomy. Again, we are not magicians. Doctors are not magicians, but everyone of the equation doing his job. Sometimes we don't know, sometimes the doctor don't know, but this is the limitation of human being. Then we will discuss the anti-aging modality, which treat the new dimension of the aging, and then we can position a different concept. So let's dig. Now, this is the layers. Again, we're not discussing skin anatomy, it's facial layer anatomy. So let's start from the bottom. First, we have here the skin, then the subcutaneous. And again, please, if something is not clear, something is missing, interrupt. So we have the skin, we have the subcutaneous, and then this layer, we have this, it's called SMAS. Is SMAS familiar with most of the people? Okay, SMAS layer, very good. And then we have the muscles and ligament here, this one. So skin, subcutaneous fat, or sometimes we call it superficial fat. SMAS, which is a fibrous tissue, exactly like the collagen, but more dense. And then the muscle. The importance actually of the SMAS layer, and we will see it later, when we have, let's say, a static layer and a dynamic layer that it has to move, which is the muscle. So in order to transfer the movement from the muscles to the skin or to the static layer, we need to have a connection. So the connection is the SMAS layer, and it's a dense fibrous tissue. So this is the fiber, this is the muscles, and then this is the magic start. It's another layer of fat called deep fat. And after 2016, they start to say it's like, oh, we have discovered that there is a superficial fat and a deep fat. Or let's say in a different way, it's not a layer, but it's a compartment. So it's like boxes. It's not covered by all the face. This is why it's missing from here. You can find it here, but you cannot find it here. So, and this is very common phrase now, fat compartment. Before 2016, that was not there. Okay, so we always, and this is why doctors, dermatologists, before 2016, we're focusing epiderm, derm, subcutaneous fat, that's it. What's behind belongs to plastic surgeon. Nowadays, no, it's changed. So here we have the deep fat, and then another fascia, which is deep fascia. And because there is a fascia, we expect that there is muscle behind it. So there is another layer called buccal muscle. And again, this, it does not spread all over the face. It stops here in the temporalis. We'll go through it again. And at the end, we have the bone. Good. So these are the layers. Again, we have the skin, subcutaneous fat or superficial fat, SMAS or superficial SMAS, and then we have the muscle, then the compartment or the deep fat. This is very important part. And then we have the deep fascia, and then we have the pacinator muscles, or let's say deep muscle. Later is the bone. Good? Shall we move? This is another cross section. So again, here we have the bone, the skull. Let's consider from the top, and we'll go also from the down. So skull, bone, deep SMAS or deep fascia, muscle, subcutaneous or superficial fat, skin. Let's go down. Okay. The bone or mandibular jaw. Here we have the buccal muscles, which was this one. Okay. But it's not there. It's only here. And then we have the compartment or the deep fat, which is here, not there. And then we have superficial fascia, SMAS. This is the deep fascia. Superficial fascia, SMAS, muscles, subcutaneous, skin. Now, the most important aspect of this picture is this. These fibers is the ligament. So if you can see ligament in medicine, it's a fibrous tissue, very dense fibrous tissue that connect bone to bone. So for the knee, I have ligaments connecting my tibia to my my tapia to the knees. And then when a muscle need to be connected to a bone, the connective tissue then named as tendons. So the tendons connect bone to muscle, soft tissue. Ligament connect bone to bone. This is only valid in the skeletal system, not in the face. In the face, on the other side of the equation, one side we have the bone, other side we have a flexible tissue, which the skin. And this is a big difference. And by the way, sometimes when you keep talking with the doctors, maybe for some doctors, there's some minor and basic information is not that clear, not because they don't know it, but because they don't use it frequently. And that small thing will be a big tool to differentiate us during our call with the doctors, and you will see now. So this is the facial ligament, which is connecting the bone to the skin, and it's being differentiated from the skeletal ligament, which is connected bone to bone. Good? Good. And it's, by the way, it's called retaining ligaments, just to differentiate the skeletal ligament from the facial ligament. So the facial ligament is called retaining ligament. It's so interesting, and we'll see now why. So just for people who have never seen the SMAS, again, it's a very interesting layer. So if this is a cadaver, it's considered to be a fresh cadaver, which is very good quality. You can see this whitish or grayish layer. This is actually the SMAS. This is fresh. This is so fresh one. So this is immediately after death, and you can see it. This is the SMAS. So it's a connective tissue covering the muscle from one side, and from the other side connected to the skin or to the subcutaneous fat. Okay? So this is how it's seen. Now, why this layer is important? Because before 2014, there was no energy device or energy-based device can reach the depth of the SMAS. So most of the energy-based device work either epiderms, derms, subcutaneous, stop. And even the subcutaneous, all of us were selling a lot of lasers that they claim lipolysis, blah, 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 and we all know that it never happened. Lipolysis, localized lipolysis is so minimal. The reason why, because there is no enough energy can reach deep, and the epidermis is still protected without burn. So once they start to use the high intensity focused ultrasound, the HIFO, only at that time, the big buzz behind the HIFO actually was it is the first energy-based device that it can reach to the SMAS layer and raise the temperature above 74, which efficient to do new collagenesis or a lot of fibrous tissues and make some fibrosis. But why HIFO is not any longer being believed or treated? It's like it was a trend, and then dramatically going down. Is this the case everywhere, or? Okay. So the reason, so now we know the buzz behind the HIFO was the depth of penetration and the temperature. So it was only the available technology that can deliver 74 or 76 Celsius temperature raise in this mass. But it has been rapidly decayed because the SMAS layer itself, actually the positioning or the claim behind the HIFO was too much. They thought if this layer connecting the subcutaneous or the skin and the muscle, and if this layer, which is a fibrous tissue, this mass, start to be loose and dull, it will bring the skin downward, skin laxity, which is logic, right? So if we have managed to induce a lot of fibrosis in that mass, maybe we will be able to retract or push up the skin and the subcutaneous, right? So that was the theory. Unfortunately, when it comes to real life, this was so subjective because the thickness of the mass layer is so subjective. It varies between patient to patient. So let's say in some patient you have a very thin mass layer, and you ask the machine to induce a new fibrosis or a new thickening of that mass layer, which is already fine, in order to lift all the above layer, the subcutaneous and the skin. So if a chubby patient with a fine mass, it will never work. With a chubby patient with thick mass, it can give mild improvement. With a thin patient, thick mass, it's the superb, it's the best candidate. So this is why the variation of the result was so subjective in the patient. This is why patient didn't like it, or the doctor cannot trust it anymore. And this was the buzz behind someone? You cannot, no way, you have no clue. You cannot make a sense because it's deep and no one can really have a test to check your mass thickness or mass lifting power. Even the ultrasound cannot measure the thickness of this mass.
In Altera, we can find it out as mass. Therapy is also available since long.
Yes.
Globally.
Yep.
And it's only working on its mass. So
Yep.
in Altera, we can scan your skin and then we find it out as mass layer because of the scanning technology.
But you cannot, the ultrasound, even if you are going to use high frequency ultrasound in order to get more details.
So Altera is not a high frequency.
No, I'm telling in about the Altera use a HIFO, which is the first one actually. It's the mother of this technology. But again, our problem is not with the HIFO technology, it's with the positioning of the HIFO technology. What happened, I request the HIFO technology to induce more fibrosis in a mass layer in order to give this mass layer the power to lift what has been redundant. So if your mass layer was already thin, okay, how much thickness do you believe you would be adding or you will be able to add in order to lift all of that weight? It's not much. Even if the technology is good and the technology is delivering the heat and the technology is inducing the fibrosis, but the amount of the fibrosis tissue, the thickness of the fibrosis tissue is not enough to retract the exist. Exactly. This is why it's so subjective. Good. Okay. Now, so that was the smash, because you will find these claims from many doctors. All the doctors, okay, for the lifting, I use HIFO. Come on, HIFO will never work, and it's always subjective to the patient. What is particular subjective is subjective to the thickness of the mass layer, which no one can predict. I cannot cut your face in order to have a look. So the second interesting part is the ligament, the retaining ligaments. And believe me, from 2016 till 2018, just before COVID, the ligament was the big buzz in the aesthetic medicine. Okay, not only for the doctors, but for the company, especially for the filler companies. And we'll figure out why. So the ligament, as you can see, it's another fibrosis, thick, dense fibrosis tissue, but in a different orientation. So this mass was like this, spread all over the muscle, and mainly it's responsible to transfer the fine expression. So when I say smile, I can smile like this. Laugh. And when I laugh, I make some expressions here. This, when the muscle contracts too much in this direction, this mass layer is moving or transferring the motion from the muscle to the skin. But when I come to elevate, let's say I do this, the ligament or the ligament that will transfer the motion from the muscle into that direction. Okay? So this is the main importance of the ligament, and why it was not clear before 2016, you will come to see. It's not easy to understand the anatomy on a cadaver because you cannot see colors, you cannot see blood, you cannot differentiate between nerve and fibrosis. It's like black and white. You really cannot, it's not that easy. So for the ligament, it connects from one side from the bone here, okay, to the skin on a vertical space. Good? And remember this diagram because it will be so useful. So again, for the anatomy, we have the layer skin and subcutaneous. Here, ligaments, and then 3 is this mass and some group of muscle. And when we mention some group of muscle, because again, the muscle is not that homogeneous. So we have some group here, it into the zygomas, and some other group lasts from the mandibular to the temporalis. So it's a different groups. This why, but in general, to make it simple, we make it like this. And then we have another type of retaining ligaments, and then the bone and the fascia. Okay, is that clear? Okay. Let's give a scenario. This is like a tableau or a portrait, and this is the wall, and the ligament would be what? What? Ligament would be what? Screws. Ligament would be the screws that fix the portrait to the wall. So just imagine 2 scenarios. First one, the ligament, these fibers, because it's a sort of fibers of collagen fibers type 3 and high dense, if it start to be weakening, so the screw start to be weaker, what would happen to the skin or to the plateau? Right. This is the first scenario. Second scenario, the muscles, which go, the fibers, the retaining ligaments, which go through the muscles, from this part or from that part. And again, take care that the face anatomy is not simple, is not smooth, it's so complicated, and you find one layer start exactly at the end of that second layer. So there is a lot of cross interaction. So if that muscle, this layer or that one start to be loose and it droop as well, what would happen to the ligament? It will droop. And what will happen to the skin? It will droop as well. The third scenario, and this is the last one. Suppose that we have a weakening muscle. So what does it mean by weak muscle? So we should understand what is the strong muscle is. The strong muscle is a muscle that can lift weight, or it can resist deformation. So let's say I'm doing like this, okay? And then strengthen yourself, you're a man. And then I say it like this. If I'm doing my shoulder, my arm like this, anyone can push, I'll be adapted. I'll go with them. Strengthen yourself. I didn't contract my muscle, huh? I strengthened it. So I can deform or resist deformation, okay? So if the muscles start to be weakening, we expect the ligament to drop. We expect the skin to drop. And then we start to have skin sagging. And then we have tried to, by somehow treating the ligament. Of course, it will improve a little bit here, but it will not improve the fixture, the muscle. So that will be always a mistreatment If the muscle was loose and we only focus on on the ligament, there will be always under treatment and missed treatment. Make sense? Good. We move. So ligament, this is how it looks. So just imagine you are a doctor. What you can see here? You can see nothing, only fat. That's it. But when someone like Professor Kotofana or someone who deals with anatomy, he will come, no, this is not fat. This is subcutaneous fat, and this is deep fat, and here we have ligaments, here, thickening, ligament, and then you start to focus. This, yes, really, let's have a focus on this. It looks like this. So it's not easy. Don't blame doctors. It's not easy. And just imagine you have to learn and understand this thing in a cadaver, on a dead skin. There is no colors. You cannot differentiate anything. Good? So now we have the ligament, we have this mass. Perfect. So for the facial element, for the facial aging, and this is the new concept actually. Before 2016, particularly up to 2014, all the business or the industry was focusing only on the skin, means epidermis, dermis, and subcutaneous. Then later, we come to dig deep more into the fat. So we come to know that there is two types of fat layer. There is superficial fat and there is deep fat. So we start to say subcutaneous fat is superficial fat, deep fat is the fat compartment. Later, we have discovered that, also, the muscle is being aging as well. And how? The muscle lose its tonicity and strength, and we'll see now how. Later, we have discovered that the bone density start to shrink. Some bones start to be elongated because of the pressure, because of the gravity, and some bones start to be thinner and thinner and thinner and thinner. So it's an element. The aging is not considered to be skin anymore. This is entry level. Professional level is a structure. So like a junior doctor, even it's not valid now, but just imagine, a junior doctor will consider aging as skin, or a superficial vision of the aging is a skin. But this is not the case anymore. Okay, so in the moment for our industry, what tools do we have to treat aging? So if I consider asking the doctor, how you treat aging? The next question from the doctor should be, which layer? What do you mean by aging? The aging of what? So I've recognized that doctor is good and he's specific. I start to be more specific. So, okay, I need to look for my epidermis. Then he will come to say, I can treat epidermis with lasers. I can treat epiderm with plasma. Not PRP, I'm talking about plasma, energy-based. I can treat epidermis, but some exfoliation. All of that can treat the epidermis aging. Okay, doctor, what you do for the derms? I can use laser as well. And then I can use HIFU because it's go deeper. I cannot treat HIFU. I cannot use HIFU on epidermis. So now I can use HIFU. I can use radiofrequency. I can use peeling, which is more aggressive sort of exfoliation. I can use microneedling. Nobody's interested to use microneedling on epidermis. There's nothing to be treated. Then I can use also injections. The biostimulator, everyone is familiar with this? Yes. The biostimulator. Okay, it is the new big thing now in the injections. Most of the patients, they don't like to inject filler anymore, hyaluronic acid. Actually, the total sales of the hyaluronic acid in 2023 dropped 30%, and the energy-based device raised to 64%. Yes. Yeah, I will resign after this. So, yes, we can inject fillers. We can inject biostimulator, which work on the derms. Question? And then the derms is checked. But doctor, what can you do for this mass layer? For this mass layer, we only have the HIFO and some monopolar radiofrequency that can have the power and the ability to reach to this mass. Okay, so mass layer is checked. What can you do for the muscle? Boom, I have nothing to do with the muscle. There is nothing to be done with the muscle. Imagine that there is no Jovena. Okay, so muscle is still the missing piece that we should treat. So let's say, sorry.
Can we get a copy of this presentation?
Yep, sure.
Oh, it's on the QR.
Okay, shall we move? Good. So now, there is some phrases. It make us, or it make most of the call actually. We are going to the doctor that expect us to throw what we have and leave in 2 minutes. Only if you hooked him with some phrases, he will feel that he need to listen. So one of the biggest phrases that we should all start to use is the facial deep structure or the deep tissue structure. We don't want to go to tell the doctor, that one is moving the muscle, that with this mass. It's not like this. It's repeated, even if it's a valuable subjects or topics, but it has been abused because it's over-treated. Muscles, mass everywhere. But if you start to tell the doctor, I'm here to address a facial deep structure restoration. Only then what you're saying, here you start to listen. Deep facial tissue restoration. So let's have a look to what is the deep facial structure. We have been covered in the beginning of the slides. The mass, the muscles, blah, 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 blah. But now we will identify which of these we consider deep tissue structure. So first is the muscle. When we start talking about muscle, this means that we have left this mass above and we start to go deep. So muscle is the most, or the first and most important part of the deep tissue structure. And here, so again, forget about the entry level. This is from the past, baby level. Now we go professional. We start the muscles. Muscles. And again, why we don't have 2 layers of muscle. Muscles are not occupied in layers, in sections, because as I mentioned before, let's say we have here, you can see this is from the skull, but this actually is at the temporal muscle, it's here, and it's being continued or intersection with the masseters, which is down. A part of the buccal is inserted. So we always have a connection or interconnection between the muscles itself. There is a lot of information in a deep anatomical level, but I would try to make it as simple as it is. Okay? So again, as you mentioned, as you can see, muscles interactions, cross interact to each other, superficial, another muscles, and the deep fat, the compartment. See, you cannot see it covered all, a whole layer. It's on compartments. Okay? So, this is temporal, the buccal fat pad, it's in compartment. And this is called deep fat. Good? The last part of the deep tissue structure is the ligament. And we have seen this actually is a ligament, this one. And there is much ligament as well. Here is a tendon from muscle to bone. Okay? Good. We move? Good. So these muscles, fat, ligaments are the deep tissue structure that we that we focus on. This is the new era. Muscle, deep fat, and ligaments. Whatever above is like entry level now. Good. So why deep facial structure matters? Where the buzz coming from? Let's have this before and after. Could anyone tell me what is the difference? Where should I look to see the difference? The skin. What skin? Brightening? Contouring? Okay. And lifting here like this? Volume? Volume? Okay. So all of that means that this patient have injected what? Filler. Filler, right? Is there any other solution to have this result? How many how many cc or how many ml of filler do you believe that this patient has been injected? A lot. Minimum 4 5 cc. Right? Minimum, right? Okay. But have you seen the volume of 4 5 cc? Actually, this patient has injected with 8 cc. 8 ml, 8 syringes. 8, 4 in each half. 8 syringes. But you cannot see the volume, right? You cannot see the volume. Before 2016, if this patient were injected with 8 syringes, you will find it like bread face or moon face. It's a bit like a monkey, right? Right? But now, it's not. It's injected with 8 syringes, but you cannot see the volume. Why? Because it's the lifting effect. Doctors start to move the application of HA, of hyaluronic acid or filler, from volumizing to lifting. And this is the effect. Patient would like natural result. They need more lifting. So the lifting is the most high demanded application nowadays. So this is why deep tissue structure matter. We have a concern about this. We should invest more and more on deep tissue structure. If someone telling me, okay, Mahmoud, take this device, it generate heat, it shrink collagen, it induce blah, 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 I'm not interested. It work on the derms. It's not the trend anymore. The trend is the deep tissue structure. Good. So when we say deep tissue structure aging, what does that mean? What is the sign of deep tissue structure aging? When we see some pigmentation, we know that, okay, this pigmentation could be superficial, could be dermal. So we know if we see some wrinkles, before we thought that it is superficial, it's a dermal issues. Now the judgment is different, and I'll show you how. So actually, one of the most important deep tissue structure aging sign, where I look to you, okay, I know you have a deep tissue structure aging. One of the most important sign is the forehead wrinkles. These wrinkles, the grooves, is not from the epidermis or the derms. Totally not. This is because of the muscle and ligament. I'll show you how. Deep nasolabial fold. We all have a nasolabial line, but when it age, it becomes deep, thick, and long. So this is a deep tissue structure aging. Exactly what's happening. Now, we have, let's have this one. Oh, oops. All of them, I'm going where? Yep. So this is exactly what's happening to induce the nasolabial fold. Here, we have an extension of the buccal fat, and the SUF, the fat underneath the periocularis, the muscle, here, this muscle. So, when the periocularis muscle or the zygomatic muscle start to be loose, droop. It have a pressure on the deep fat, so it cause a fat migration, deep fat migration. So this fat move because of the pressure of the muscle, and it bring us a nasolabial fold. Here, the buccal fat, when it has pressure due to the looseness of the masseters, it give us the jawline sagging. So actually, when we lose the muscle, we do a specific pressure in a one direction on the buccal fat or in any deep fat compartment, and this will do or induce fat migration that cause wrinkles, deep nasolabial, or sagging on the jawline. So this is why it's so important to understand the deep fat structure. Good. So as we mentioned, forehead is one of the most important signs of deep tissue structure aging. Nasolabial fold, jawline sagging, as we mentioned, and the middle face sagging. So nowadays, all the patients go to the doctor. Doctor, I would like to lift. They do like this, exactly. I would like to lift my face, right? And the doctor, nurse, get me 1 or 2 cc to start. Straight. Why? Because they want to use the filler to elevate the ligament or the muscles. We'll see how. Good. So, if we are concerned about lifting, what is the most important and successful treatment for the lifting? It's the procedures, operation, facelift. It's a surgery, facelift. The celebrity did a facelift. I have a lot of skin sagging. Don't trust dermatologist. Go to a plastic surgeon. In one time, he do facelift. So you save time, and actually you are going to save money, right? Because you keep doing once instead of going treatment by treatment by treatment, and the results are minimum. So surgery, what kind of surgery? It is the facelift surgery. So let's consider what is being done in a facelift surgery, which is the gold standard. So first, we get the skin, we have a cut here, and then we release the ligament, which connecting the muscle to the bone. Okay? So this is the first step. Second, we grab the muscle. Good? And then we stitch it. Okay? Then we grab the skin, remove the excess, and stitch. We don't cut the muscle here in the second step where we first actually. Sorry, I'm faster than the frequency issues. Okay. When we cut the ligament and we pull up the muscle, we don't cut the muscle. It's so stupid decision. Surgeons, they stitch the muscle over each other. We don't cut muscle because if we cut muscle, there will be a disaster. There will be a blood everywhere. And in case nobody inside the operation room have a ruler and cut the muscle straight as it is. So if he was stupid enough and tried to cut the muscle and restitch it, if there is 1 ml of gap, 1 millimeter of gap, finish. He destroyed the patient. So we don't cut muscle. We stitch muscle over each other, okay? Good. And then we cut the skin. There is no problem. So these are the main, the most important element on the face lifting. Again, what was the main element of face lifting procedure? The muscle. Some doctors are doing what's they call mini facelift, that they don't touch the muscle, they only grab the skin. but they don't touch the muscle. And this is called mini facelift, and the failure rate of this procedure is very high. So no plastic surgeons anymore do very high. Yes, it recurrence, always recurrence. Let's say you do it today, in 2 years, your skin has been sagging again. Why? Because you didn't treat the cause. And this is called mini facelift. In mini facelift, we don't touch the muscle. We keep the muscle only subcutaneous and skin. And this is why its failure rate is very high. So the muscle is the main element or target for the facelift procedure. Is there any other non-invasive solution that can work on facelifting or can claim for facelifting instead of facelift procedure or operation? Actually, yes, our beloved and all doctor beloved hyaluronic acid. Doctors love to inject. No injections, no doctor. They feel attached to the injection because actually if they don't inject, their skill does not matter. I can bring a device to a beautician, to a doctor, to whomever, work and get a good result, and doctor, bye-bye, you stay at home. So it makes no sense. Even from our perspective, it's so stupid that we go to tell the doctor, this is going to blow your mind, giving a great result, and it will replace the filler. This is so stupid. Then your next step is the door. So we cannot replace filler in our call. And this, what Attilio was trying to find, to tell this morning, it's an added value. Again, we don't want to position Jovena as a complementary effect. During our call, we would like to position Jovena as a standalone technology that you can count on, but how? Without replacing the filler, okay? So that would be so essential. We are not going to replace filler even if we can, okay? So yes, the hyaluronic acid filler into the deep fat or under the muscle, it is the new non-invasive way to treat facelift. Deep fat, hyaluronic acid in the deep fat or under the muscle, which cause an effect called ligament effect. Okay? Good. So let's review. Again, we've mentioned that there is two types of fat, superficial fat and deep fat. Sorry, there was a lot of details. Actually, I forgot to remove the arrows, but there was a lot of details, anatomical details. So superficial fat, which is the subcutaneous, it's spread as a layer, and this, which has been used before to give a volume. So whenever a doctor or a patient would like to inject filler to have volume, we inject on the subcutaneous fat. But when the doctor or the patient would like to induce lifting, not volume, we inject deep under the muscle or in the deep fat in order to induce something called ligament effect. So they inject here in some different points, in order to lift the muscle or to lift the ligament. Okay, so it's called ligament effect. And this, for the moment, considered to be the only one reliable, easy solution for a facelifting. And all doctors love it. Okay, so again, to summarize, we have the hyaluronic acid or HA filler to be injected in the subcutaneous in order to induce volume. Okay, so we are injected here in this layer, subcutaneous, everywhere, this. So this is the subcutaneous fat, huh? You can see it above the muscles. Good. If we inject deep into the deep fat, here, down below the muscle, we are going to achieve lifting effect. It's here, this, down below the muscles, between the muscles and the bone, between the ligaments and the bone, or underneath the muscle itself. Is that clear? Good. Something? Good? We move? Okay. So, having hyaluronic acid or a filler as the only one reliable solution and affordable to do facelift or non-invasive facelift. What could be the limitation? The biggest limitation are the volume. Patients, they don't like to be injected a lot. That patient whom injected 8 cc, first of all, that was in 2021. Nowadays, 23 or 24, if the nurse bring 6 or 5 syringe in front of the patient eyes to be injected, the patient will say, no, 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 I don't want to be that much. No, it's too much, doctor. Whatever the reason is economically, because yours, or because Blumpy. Whenever he see that amount of filler, no, 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 doctor, please, no, 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 no. I don't want to be like a bread. My friend will make fun of me. No, 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 no. And the doctor keep swearing. I swear you will not look for this. I need here just 1 cc and here just 0.2 and blah, blah, blah. No, 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 no. Make it 2, make it 2. And then the doctor begged the patient to make it at least 3. Not because to have more injection or profit, because 2 cc will barely give you a lifting effect. Barely. Because we inject here 0.5 and here 0.2 and here 0.3, here 0.5, it's almost 1.5 cc. And we did nothing. We still need more. So we have passed already 2 cc, only in 1.5. And the patient start to complain, economically or like psychology. So this is one of the main limitation. Patient don't like to be injected with volumes, not anymore. Toward more natural effect, natural look. Exactly the same as the patient you have seen. You say that she injected 1 or 2 cc, but actually she was injected with 8 cc. But no one can recognize because lifting. So this is actually the intro of how we should position Jovena as an added value to the doctor, not as a second or complementary effect or a replacement. So when you come to tell the doctor, the most demanded application nowadays is facelifting. Yes, yes. So you are injecting your filler under the muscle or the ligament or into the deep fat in order to generate lifting effect. Yes, yes. Unfortunately, you need at least 3 to 4 cc in order to have noticeable result. Yes, yes. Unfortunately, patients, they don't like to be injected maximum 3 cc. Yes, yes. So you have, let's say, 50% results out of 2 or 3 cc. What if I gave you a 100% result, but still with the minimum amount of filler? You got it? So the patient, yes, the doctor can have the best results for lifting using minimal amount of filler. How? Because I'm working, why I was using the filler underneath the muscle? To lift the muscle. What does it mean by lifting the muscle? It's not like you're anchoring the muscle. It's not like this. This is not happening, okay? Because first of all, your face is not layered like this. Your face layered like this. So actually, the more you inject here, the more droopy effect you will have, okay? So what's happening, by injecting underneath the muscle, you generate an effect called myomodulation effect. It's not here in the presentation, but that one is so deep, we can discuss it later. But anyhow, so when you inject filler underneath the muscle, you generate tone in the muscle, and the muscle restore its tone, or you generate anchor underneath the ligament. So the ligaments start to pull the structure. So this is the point. If I'm using the filler to induce muscle toning or retoning, I do first the toning of the muscle, which I reach to the maximum, what I can do, and then the final touch, the fine tuning, I will use the filler. So the patient will get the maximum effect of lifting with only 2 cc of the filler. So the doctor still can use and can work and can generate money even if he's not in the clinic, but also he can reach the expectation of the patient without losing any injection. If the doctor loses one injection, he can sacrifice the whole device, but not losing a possibility to have maybe 10 or 30, 50 euros profit from injection. So in this way, doctor should not lose, but has an added value. He can claim, I'm the only one, blah, 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 that can reach that effect with only 2 cc. And then go into the social media with the patient, how many cc you have been injecting? Only 1. Ah, that's impressive. That's incredible result. You agree, Jose?
No, yeah, but I want to know.
This is enough. Okay, there is more. Okay, so yes, so this what I was telling, that nowadays the muscle is the most important. Then the only reliable non-invasive treatment is the filler. But there was one so common treatment. It's tricky, which is the thread lifting. Is anyone selling threads? Okay. Actually, when they have invented the thread, the idea behind the thread, that the thread having hooks, so the idea was to insert the hooks or the thread into the muscle and start to grab. So we hook the muscle to the subcutaneous tissue and we lift. In practical, this is not happening. Why? Because it's not possible to play with the patient muscles, invasive, and the patient will stand still. He has to do a nerve block. It's not option. And then they said, okay, forget about the muscle. We just keep it on the subcutaneous, and we try to hook with the fibrosis tissue in the subcutaneous, with the fiber septa, blah, blah, blah. But again, this means that you are hooking a thread which you expect to hold the tissue only based on the fibrosis on the tissue. So if the tissue have no fibrosis or weakening fibers, the hook effect is not working. This is why thread lifting is becoming more subjective. It varies from patient to patient. Plus, it's taking a long time, a really long time. And the effect will not be dominant. Okay? So thread lifting, I can't consider it's a competitor. Our only or parallel competitor or parallel treatment is the filler, not the thread lifting, not anymore. Okay, so if all of that business of lifting, we're focusing on the muscle, so why we don't work the muscle out? We go directly to the cause. We treat the cause. And here, Jovena start to come. So again, finally. Yeah, actually, it's 70% of the call is the intro, because it's you keep in the subconscious of the doctor, you keep pushing a positive point, and then he will start to be like, Jose, yeah, okay, tell me what's there. I'm cooked already. I'm ready. And then, yes, and then you get some spices, you are in. And believe me.
It's a very good USP point that we can collect from presentation.
Exactly.
Absolutely. We can push on our place Jovena is like.
Exactly. And this is what I mean by we create the global momentum. And believe me, our company is well known maybe in the Gulf, but let's say for some countries, we don't know. But you get me any key opinion leader, and we will go through this. In 5 minutes, he will be your loyal customer, and he wish to be a speaker for Jovena. If we go through this, why? It's so interesting. The call is so interesting. And be sure, nobody, zero, even BTL, talk the same way or position the same way, and I'll tell you why. So it's only us.
Wow.
It's really only us. You will never find this call from any other competitor. Zero. I mean it 100%. Unless someone of you left the company and okay, good. So, yep, again, back to the muscles. So, when, so important, we've mentioned before, it's called the ligament of the fascia, we call it a retaining ligament. And we were trying to differentiate the skeletal ligament from the facial ligament. So the facial ligament, we start to say retaining ligament. Ligament means skeleton, retaining ligament for the face. Muscles means for skeleton as well. In order to differentiate the facial muscle from the skeletal muscle, we call it mimetic muscle. So what's the difference? Yes. What's the difference actually between two muscles? They are muscles. But for the skeletal muscle, they connect again, or they are being connected between bone to bone. But with the mimetic muscle, between bone to skin. And there is a big difference. I will tell you how. For an example, with a bodybuilder, they like this, their biceps like this. The more biceps grow in volume, the more fold of the arm, right? You'll find them like this. They cannot stretch. They cannot stretch. Why? Because their muscle, their biceps, connected between bone to bone. So the more volume, the more fold effect. This is not true at all a muscle. And imagine, again, unfortunately, I would say 80% of the doctors, physicians, they always have misconception. So they tell you, especially Dr. Google, high expression, don't smile too much, otherwise you're going to induce wrinkles. There is zero publication of this. This is a Google. And why? Because they say, yeah, because you keep moving a lot, so you have a contraction. And okay, if this is true, who is the most creature on earth do a lot of contractions? The neonate, babies, they cry a lot. They cry a lot. They keep crying 24 hours. Why they are not inducing wrinkles once they reach 9 years old? I think in this period of life, you are generating the most of your contractions. So why you are not developing wrinkles by 9? So it's not, the mimetic muscle is not a skeletal muscle. When you contract your muscle, you cannot be contracted all the time like this. This makes no sense. It's only the idea of more contraction, more wrinkles, valid only if you do like this. Actually, what's happening, it's not only because of the contraction, but because of the breakage and the damage of collagen and elastin. So after the contraction, your muscle come to the rest phase or the rest condition, but your skin not, because it lose elastin. So this is something else, but has nothing to do with the contraction, okay? So when mimetic muscle age, what does that mean? When I say, Uthai, you have an aging in your mimetic muscle, what does that mean? How come you know? This means that your muscle lose some of its mass. It does not mean, because in some papers, they misdescribe this, they say in some phrases, the muscle got shortened, or the muscle got thinner, or the muscle got lengthening. It's completely different perspective. What they are trying to do, because the people who write the paper is a medical narrator or a medical writer. He should not be aware of the different description or expressions. What they mean, muscle got shrinked. Shrinked mean in mass or in volume, and sometimes in length. But it's a volume shrinkage. It's not dimensional or linear dimension shrinkage. You cannot say the muscle gets shorter. This is wrong. You cannot say the muscle get longer. This is wrong. You cannot say the muscle get thinner. It's wrong, because if it's crumbly, it will be thicker. So the correct expression, the muscle mass or the muscle got shrink in volume, shrink, 3D. Okay? The other thing, the other aging sign that the muscle lose its tone. And the tone expression, it's like fuzzy gray zone. Nobody can catch the tone. What does that mean? So the most simple way to give an example for the doctor is the hammock. Wait, okay. What else we have? Shit. Okay. Is the hammock. Everyone knows the hammock? Yes. Yeah, exactly. I'll show it to you. Let's pause this till the next slide. But anyhow, the tone does not mean contraction. I mean, I cannot say I have high tone, so my muscle are contracted. And again, this is only applicable for skeletal muscle. For the mimetic muscle, tones mean the power of the muscle to resist deformation or the power of the muscle to lift load. Okay, does not mean contracted muscle. High tone muscle and mimetic muscle does not mean contracted muscle. When you have skeletal muscle and then you have cramp, the doctor will say, yeah, see, it's contracted. Yes, because this is a skeletal muscle. It's not a mimetic muscle. Skeletal muscle connected bone to bone. It's fixed. From one part, it's fixed. From other part, it's fixed. So when it increase the tone or when it try to contract, it has to plump the volume of the muscle. There's nothing else. Okay, so aging of the muscle means lose of the mass or the size or shrink of the size and lose its tonicity. This what we call muscle aging. Okay, so
I have a remark because in order to keep people's attention to make sure that they come back on time because they're all captivated by your speech, shouldn't we launch the lunch now because
Yep.
it's ready?
Good.
And I know
think it's
that they
good.
will be on time, Romania, Spain, to the following slides because they really loved it.
great. True. But we need to get energy. Habibi, thank you. Yes. So we'll continue after lunch.
It's true that there are doctors that tell me, but
Wait, sometime?
Now start.
We start? Okay. Okay. So, yes, so now we understand the main concept and the importance of the muscle and the deep tissue structure. Okay, so as mentioned, when we mention aging for the deep tissue structure or the muscle agent, we mean shrinkage in mass and loss of tone. Good. Okay. So as Utai was saying, it's not a disease, but it's a physiological condition. It's called sarcopenia. The sarcopenia is the physiological condition where by age, the mass of the muscles start to be shrink and shrink and shrink. And this why for the elderly, old people, you find most likely start to lean forward. Why? Because they cannot tight or they cannot, let's say, tone or strength their muscle at rest. At rest, it's a so important phrase. At rest means in the normal state. So if I am at rest doing like this means that the central neural system, usually the central neural system is sending a signal. It's called a threshold or a bias signal to keep the muscle in a semi-tight or a semi-contracted or a semi-intense phase. So this why, because in case of accident, in case of emergency, you have a fast reaction. So you don't wait till you build up the action potential or the signal into the axon, into the fiber. By that time, by we age, the threshold or the base signal in the central nervous system is getting weak. So this is why you find the muscle loose, and then because it's not moving a lot, it starts to shrink in size. So this is the sarcopenia, and sarcopenia have been proven to be in the skeletal as well as on the face or the mimetic muscle. Okay, so we have discussed the loss of mass, and now let's see how loss of tone will affect the skin. So actually, this is the zygomatic bone. It's here. This is the skin, superficial fat, deep fat, muscle. So at youth, when you're young, you can see that the muscle, let's say, strong. And I don't want to say strong and tight, because tight muscle, doctor will explain it or understand it as contracted muscle. So please don't use tight. No, we say strong. Okay? And again, this is a very big misconception. If you mention, doctor, we are tightening the muscle, you lose. Because you tie the muscle, I do this. And then I keep doing this. This is not possible. So we are not tightening the muscle, please. We are not tightening the muscle. We are restoring muscle tone or strengthening the muscle. No tightness. Okay. So again, bone, skin, strong muscle. Let's see after aging. The regular, what happening is the muscle lose its tone or lose its strength, so it will start to be dull and droopy. Because the muscle is fixed, it's a mimetic muscle, so this means it's fixed from the origin to the bone and from the insertion to the skin, so it's logic. Once it's drop, it will draw back the skin and this fold start to appear. Ah, yes, no. It's, sorry. Deep fat, muscle, superficial fat. Yeah, it's a mistake. Someone will be fired for this. Yeah. You're so gentle. Good. So, when the muscle lose its tonicity or the muscle get weaker because it's connected from side to the bone, other side to the skin, then this retraction happen, and then we can find the fold. Okay? Good. So this is the effect. This is the effect of tone, of loose tonicity. Again, this is the right example of tone. What does it mean by tone? When we buy the hammock, it's tight and it's good. And then after use, we go and jump and relax. Let's say 6 months, we find it start to be loose. But when you measure the length of the ropes, it's the same. Nobody come to add extra length, but it loose. Why? Because the rope which hold the hammock is losing its tonicity. This is the best example to let the doctors understand that tone does not mean or have nothing to do with contraction. Tone is to avoid or to resist deformation. So the rope was trying to resist the weight, and because that was a new rope, it was hold. By time when it age, sun, too much pressure, the rope start to lose its ability to change or to avoid or resist change or deformation. This is exactly what's happening with the muscle. Good. So one fact to remember, a strong muscle does not mean contracted muscle. Again, this is so much important because all the doctor, when you say, you strengthen the muscle, equal, you are tightening the muscle. And if you tighten the muscle, you will be like this all the time. And it makes no sense. Okay? It's just a small expression, but ruining all the business just because the wrong expression. Good. A strong muscle mean that the muscle tone, okay, that the muscle tone at rest. At rest, this is a very important expression because this what we should treat actually. Do you believe when a doctor tried to treat the forehead lines with a Botox, do you think that the patient go to treat dynamic wrinkles or the static wrinkles? You know what's the difference? The static wrinkles is I'm at rest. You look to me, you find a shallow line. Because I'm at rest, and you find this line, it's called this static line or static wrinkle. So it's there all the time. But when I have some expression like this, like this, like this, I develop some different fold or different wrinkles because that fold or wrinkles developed due to expression we call dynamic lines. So when doctor treating a patient with Botox, we are targeting the treatment of static line, not the dynamic line, because we have born, God put us the ability to express ourselves. We do like this, we do like this, we do like this, but at rest, we should have no lines. So what doctors do, they try to treat the static line by reducing the dynamic line or the ability of the dynamic lines. And this is why they inject Botox. And this is why and this is a total new channel. Face mask, especially with the celebrities, you cannot inject them too much with the Botox. Otherwise, they lose their expression. So you have to reduce the amount of injected Botox. And it's the same scenario with the filler. This is why we call it Botox booster. We are not going to discuss this time because it's so deep as well, but at least you know that we're developing something called Botox booster with the Jovena. Good, so strong muscle does not mean contracted muscle, does not mean tightened muscle. Good? We move. Not good. Yep. It will be there in the QR code. Okay. But it's okay. I'll do it. This one?
No, no, the final one, the one that.
Okay.
Eccolo qua.
So strong muscle means the muscle tone is defined as the tension present in relaxed muscle at rest. Contracted muscles mean muscle fiber contracted only while doing a physical activity. Okay? Good. Remove. Show. Good. So as Othai was saying, actually in our face, there's two group of muscles based on the action or the direction of the direction of work at rest. Mean I have nothing to do. I'm steady still, and at that moment of time, there is some group lifting at rest. It's involuntary. One group lifting my tissue or deep structure upward, other group pulling downward. And this is called elevator muscles, depressor muscle. And now the real business is coming. Okay? Just now. Okay. So at youth, there is an equilibrium between the force of elevator muscles and the force of the depressor muscles. Okay? This is at youth, at the beginning. So what's happening later? Both of muscle group start to be weakened and affected by age, but in a different level. But both of them start to be weakened. But because the depressor muscle work toward the gravity, the dominant effect will be for the depressors, not for the elevators. So the dominant effect, and this is another important phrases, the dominant effect will be more to the depressor. This is why we have skin sagging. This is why we have the nasolabial fold. Because let's say, imagine I have this muscle, the zygomas and the superioris, pulling up. On the opposite, there is the dow muscles and the rhizorius pulling down. At Yath, this was exactly the same as this. By age, this get weakened, but this is more, not more weakened, more strong because it worked toward the gravity. So here, at by aging, what pull the skin down is our depressor muscle plus the gravity. Good. At that time, the elevator muscle cannot lift alone all that. Okay. Before at Yath, it was good. There was an equilibrium, so the gravity contribution to the direction was zero. Now is not. The same for the forehead. We have frontalis up elevator, corrugator down. At the beginning, now this is so important and so interesting. I'll just go quickly, but later we can go deep. Here, it go up, this go down. And on vertical, in this direction, we have the ligament. So when the muscles start to be loose, it drip down, and we have a ligament as an anchoring. This is why you find the horizontal, the line here is horizontal. And you find the line here is vertical. Why? Because the ligament here are horizontal. So the direction of the line is opposite to the ligament fixation. And this is why we have it here. It's, yes. Because, now a question. If I'm having the elevator upward and the depressor downward, why I have a horizontal line? Why I don't have it as a groove downward? Because actually, the muscle is like this, and the ligament is 90 degree on the muscle. So when the muscle is losing and going toward the gravity, what's happening to the yes, exactly. So you are anchoring the skin with the ligament, and the back wall of the ligament is growing down. So it will push the ligament and the skin down. Welcome. Good. So the target is to achieve the balance between the depressor and the elevator. Okay? So when we say we are restoring the tone of elevator muscle, not for the depressor muscles. And it will be so stupid if we find some companies doing these electrodes on a depressor muscle. So you find the movement like this. What exactly you're doing? Okay, this is different than what we are doing now with Uthai protocol, because we are using higher frequency, higher cadence. So this is not like our protocol when we do fixed. So we will keep use Uthai protocol as well, the original protocol, for the jawline. But when we use that, let's we call tone restoration, we will work only on elevator muscle, only. And this is why during our call for the sales, my experience is to avoid telling the doctor about the frontalis. Why? Because you are going to dig into one of their main business, the Botox. You touch anything. I can accept filler, 1 or 2 cc syringe, but I can do more treatment, but don't even think about Botox. Okay, this is like the indignity of the doctor. This is the ego of the doctor, because Botox is only based on the doctor's skills and anatomy. Okay, so please, at least don't mention we position ourselves as low and mid face lifting. And while doing the treatment, you do the forehead. And then it will be a totally different call. Totally different call. But it's great. And this is why we got the attention of most of the key opinion leaders. So our goal again is to achieve the equilibrium between depressor and elevator. Okay. Now see how the equilibrium state is achieving or working behind the skin. These are elevator muscles. I will exactly see it's open, it's lifting the tissue, the muscle, and here it's a depressor muscles. If this was not there, you will find our whole face going like till this, till here. If there was no opponent muscle or antagonist muscle or opposite muscle, it's called opponent, antagonist, or opposite. Okay? So it has to work on an equilibrium. This is what exactly happening. Good? We move. Jovena, finally. Okay, we have 2 minutes and that's it. Good. So dynamic peak. What? You more experience in this. But one important, super important. Where is Luca? Thanks to Luca. The brain. When you call to any doctor and tell him, okay, that's fascinating. I'm super excited about Jovena. What's technology to use? And then you say, it's radio frequency. Radio frequency? How come? All of that brilliant talk for a radio frequency? You are a liar. Right? Right? This is happening. And then you say, but why they are saying this? Because radio frequency devices is so common, it's a copy. Replicas. Monopolar or bipolar or quadrupolar, ultra multipolar, whatsoever. It is there to generate heat. Right? And this is the strong, this is where we show our muscle. We tell the doctor, it is radio frequency, yes, but it does not generate heat. Or you have the key to generate heat, switch off, no heat, or heat and muscle contraction together. But once they listen, radio frequency with no heat, it's like an Mars technology, space technology. It's not from the Earth. Why? Because they use radio frequency means heat. It's in our DNA. You are changing this totally. And then the next question. So what's the new about the radio frequency? And then Lucas said that it's a new pulse called myomodulated pulse. This is the secret. Okay. So we will not explain because it's patent and we don't want to break it, but we will explain what is required. I will tell you. Okay, sorry. Mayo, from where it came, you mean? Mayo mean from myofibers, the fibers of the, this is a trade name. It's a business, marketing name. So the myo means the myofibers. Modulated means that manipulated. Good. Pulse is the pulse. Good? Okay. And pulse means pulse. I cannot explain more. Okay. Okay, let me make it more simple. The fibers inside the muscles, okay, it's originated. You know the fibroblast inside our skin and the derms? It's called fibroblast. In Greek, plast mean factory. Fibro because it produce fibers. The same, we have fibers in our muscles. In the 3D video that I was showing, it was like fiber strands, right? It was fibers. So it's fibers. It's called myofibers because instead of the fibroblast, there is a cell, mitochondria, something like, not mitochondria, mitochondrial cells. It's the cell that produce, or the connections in the fibers that produce the fibers and increase the number of the fibers. It's the cell, I will show you. Okay, see? Now here, these are fibers of the muscle. Let me tell you as a question. What is the difference in muscle when I left 5 kilograms or when I left 100 kilograms? I have my biceps. I ha- exactly. Let's consider here I have 1,000 fibers on my biceps. Okay. So I have 5 kilograms. The amount of fiber required to be engaged in order to let me hold the 5 kilograms, let's say it's 100 fibers. Okay. So I get 10 kilograms. If I count only on that 100 fibers, it will not allow me to grab or handle that load. So it will involve more number of fibers. Let's say 2,000 or 200. If I'm with the more load, the more fibers should be involved. Okay, and this is why when we go to the gym, you start with a fresh load. Let's say first 2 days, maybe 10, 15 kilograms with the biceps, and then you don't feel the pain anymore, right? You find it very simple. But then you tell you have to increase the weight in order to reach the break point, right? So the fatigue, where you cannot hold anymore, right? Once this break point start, the fibers actually get broken. And this is why at evening you feel soreness and pain because you have injury inside your muscle. And because you have injury inside the muscle and the muscle try to heal itself, it trigger that cell, which I don't remember, I tell you, but in order to promote regeneration of more muscle fibers, or thicker muscle fibers, either more in numbers, either more in thickness. In numbers, there is a debate because they say the mammalian cannot induce more fibers, but they can increase the thickness of the fibers. Okay? So anyhow, this is why you get bigger muscle because the fibers has been increased in thickness or in number. Okay? So this the reason why we call it fibers because the muscle is fibers, myo because of this myo cell. I'll get it for you. Good? And modulation because we alternate or manipulate the pulse where was Lucas saying it is not just as any sinusoidal wave. It's not like this. There is a sinusoidal wave that carry a different pulse, and this is why I say it's 300 kilohertz, which is high frequency. Other than this, you will find a lot of competitor coming in your market. I'm not sure what's the situation in each market, but we have a lot because companies start to follow us. But we have a very strong weak point against one of each. So whenever you have a competitor, you can text me or send Uthai, and we will tell you all about it. Good. So our unique technology or training claiming is myomodulated pulse. Why you do this? Why your radio frequency cannot produce heat, or why your radio frequency is having the privilege to produce heat or not to produce heat, or to produce contraction only, or to produce heat and contraction, because it is the myomodulated pulse technology. Good. So as Luca was saying, it's a single modulated radio frequency source, which can give a deep penetration. Why it is important to say deep penetration? Again, as I mentioned before, the muscles are a group of fibers. If your stimulation was being only for the superficial amount of fibers, this means it's a muscle twitching. What does it mean by muscle twitching? Like this. Okay, so as long as I can do it, it's called twitching. Okay, but what we want is a full or a supra max muscle contraction, which is a contraction that involves the whole fibers of the muscle. And this cannot be done voluntarily. You will see the contraction. No one can do it voluntarily. So if your stimulation is not going deep, this means that you are triggering the superficial layer, which will induce muscle twitching. Right, Luca? Good. So this why it's so important to show deep. So one of the selling point in the myomodulation signal that it's deep, that can target the whole mimetic muscle fiber, and still you can control the thermal effect on or off. And this is brilliant, really. If this is patent and we can still secure the patent, this means like in 1 year time, Attilio should get his Ferrari, right? Ah, really? So what's the point of the meeting? Ah, yes, one Lemo is the twin of the Ferrari. Ah, yes, exactly. This is promise, huh? This is promise. Okay. Now I'm happy with my G. Okay, good. So now you got the idea for the elevator muscle and the depressor muscles. We know about the technology, the myomodulated pulse, and this is super important. Ah, sorry.
One question. I'm a bit confused when it comes to the muscle strength and ratio.
Okay.
All that I understand about muscles is we need some sort of resistance to get hypertrophy, to make
Okay.
muscles become bigger fibers. And I'm not
Okay, let me interrupt you here. We need a sort of resistance in order to induce muscle atrophy, or muscle atrophy means thickening of the fibers. Okay, so let's make it simple. We need some resistance in order to induce thickening of the muscle fibers. Okay, this is what we say. This is what we know, and this is why in the gym, see again, you are always comparing exactly as the same as the doctor, always comparing what you are saying with the gym. It is not right because the gym targeting skeletal muscle, here targeting mimetic muscle. But even though, let's continue. Nope, it's not even the same. It's not the same. Why? The point is, you need load. You don't need resistance. When we go to the gym, we need load, and they call it resistant training with the ropes. Actually, what they mean that they create the load through using our body through the rope. This is why they call it resistant. But actually, it is a load. Okay, you pull or you grab weight, a load. It's misconception when we say resistance. Okay, so the correct, we need a load to hold or to lift or to grab in order to achieve the breaking point, so we increase the muscle fiber thickness or numbers. Is that clear? Good. You go to the gym, you would like to go to play with your crunch, your app. If you are a professional, you do something called lock position. What does it mean? The lock position is the position where you focus your training only on the group of the muscle desired without the help of supporting muscle. You try to go your exercise your app, you will find the soreness here, right? And the soreness here in thigh. These are supported muscle, but you are not targeting this. Try to lock your muscle and focus your exercise only in that group of muscle. The rest of the body muscle will not be involved. This will give you something called supramax contraction. By lock out positioning the muscle, you induce or you trigger the contraction in the whole fibers of the targeted muscle. But when you are not into a lock-out position, you are grabbing the assistance of whole neighbor's muscles to help you to do the contraction of that group of muscle.
some sort of load. Upper body is a load that you're using for weight.
Yes, this is why for the lock position, like for the abs, you know, there is There's one machine in the gym where you have something like a ball, and you rest your back, you rest your elbow, and then you only play with your. This is a lockout position. Your thigh is not involved because it's free. Your arm is not involved because it's rest. Your back is not involved because it's rest. So you are moving the whole load of your body only with your abs. And this is the best exercise, but it's only for professional level. Why? Because it's achieving a lockout position, which means you can only contract the whole fibers. For the mimic face or the mimic muscles, you cannot do this because the muscle is attached to the bone from one side and is free from the other side. You cannot do a supramax contraction for the whole zygomatic muscle, voluntary. You cannot do it voluntary. So this means you have to get a strong stimulation. Okay, and this is why we use Jovena. Does this answer your question? So the point, what makes you confused is that you think we need a resistance. It's not resistive training. We need weight or stimulation without weight. So weight, if you have weight or load, you induce voluntary contraction because you are the one to apply the load. But if you have the contraction without load, it's involuntary. I mean, see, if you're doing like this for 10 years, it will not do any effect for the lifting effect. Do this from now till just 2 days before you die. Nothing will happen. Because this is voluntary movement, which you don't have load, so you only do muscle twitching. This means muscle twitching. This means muscle twitching. If I'm doing this for 10 years, do you believe that I'm gonna have like 1 centimeters growth from the body? No. So the target, not only the load, but the target behind the load is the supramax contraction. If you achieve the supramax contraction by applying weight, this is one point, this is one way. But if you cannot apply weight and you still achieve supramax contraction, you will have the same effect. Good? Once we go through it and we'll have it live, you will get it. And I'm there still if you need to talk about it. Okay. Now this is more clinical. And based on that, we will go to fire the devices. Again, we don't work because once you start to talk on this, doctors will start to respect you more and get you as a source of information. So they will ask you, what type of muscle? You say the elevator muscles. Which muscles you are considering? We are considering the following. And unfortunately, this you have to know the expression. It's not hard. It's simple. Only one muscle sounds weird, but by practice you will get it. So in the forehead, there is one elevator muscle called frontalis. This and this. It has two big. One. Good. Okay. In the mid face, we have here in the nasolabial, we have supralabial superioris. You can say levator labii, you can say superioris, whatever is catching your mind, it's okay, it's understood, okay? You can make the labia, okay, like this, and then they catch it, okay? Because all the doctors know it. Good. The second muscle in the mid face, the zygomas, zygoma major and minor. Good. Now, in the lower face, we have the rhizorius. This is elevator, by the way, it's not depressor. And on the device, I will show you how to differentiate between the depressor and the elevator, and the masseters. This is the beloved one for the jawline. So, upper head, frontalis, mid face, zygomas major and minor, superioris and the risorius. For the lower face, masseters. Good. Move.
So 6 months. 6 months by
Yes.
basic one.
Yep. The whole. Your next question. The whole treatment take the whole face, forehead, upper, medium, lower. Take around 45 minutes.
How is that? Is there a technical way the mapping, like, I mean,
Yes.
distinguish the
Yep.
differences and
Yep. I'll show you.
frontal is a bit more complicated.
I'll show it in the during the treatment. So now we are familiar with the muscles. Now, so actually, what we do, what we are targeting, again, and this is very, very strong point of the myostimulated pulse or myostimulation pulse, because we are we have the option to be a non-thermal. This means that we can stimulate. What we are stimulating is the nerve. Okay, we're not. There is the muscle has nothing to do without nerve, because the nerve is giving the signal. Okay, or the action potential. So we are stimulating the nerve, or exactly the motor nerve or the junction point. I will show it. But because we have the power to make non-thermal effect, what we see is not edema. And if the doctor tell you, oh yeah, but no, this is coming to the nerve, and if some side effect happen, the patient will be paralyzed. This is bullshit, because the nerve will only have two type of damage: either injury, cut, either trauma, like a big accident. So there is nothing called a nerve or a patient paralyzed because of overstimulation. If you laugh a lot, are you afraid of paralyzing? If you cry a lot, are you afraid of paralyzing? Only if your nerve got cut or get trauma. That's it. But no, like side effects or paralyzing, or this is bullshit. It's nonsense. Okay. So thanks to the non-thermal ability of the radio frequency to give us the prolonged stimulation. What I mean by prolonged stimulation, that really you need to stimulate the muscle for some time. You cannot work around like this. It's not.
This, I really like what you say about the time, because I've tried we tried a lot of protocols, and the ones that have 10 minutes, like,
But once,
it just doesn't work.
Yeah.
It works, but
Exactly.
not anyway.
no, actually, it's totally opposite. If we do a short time, because what we are looking for two things: for the supramax contraction, and in more depth, we are looking for something called the maximum repetitive stimuli. This is a condition where the action potential or the axon, the nerve, is full of action potential. We will discuss it in another way. Okay. Now, let's see that, let's prove that what we are saying is not science fiction. Okay. This is a young patient, but it has a medical condition. She lost 70 kilograms. Of course, she has a sagged face. It's clear. So this is a pathological case, meaning that she has a disease, losing 70 kilograms. So we get an ultrasound to measure the zygomas, the thickness of the muscle. Okay. So we try to see the reference before and after after 4 sessions, and with other patients after 3 sessions. I will show you the difference. So before, the thickness was 5.7 millimeter, the thickness of the zygoma. We can do this easily by ultrasound. After the 4 treatment, it was 6.9, which means gain 21% of muscle mass. So the muscular mass increased 21%. So this is a proof. 1 week, 10 days, between 1 week to 10 days, sessions. We will discuss the protocol. 4. After 4, it was 5.7, then 6.9 after 4 treatment. Okay. The right, that one was the left zygoma. The right zygoma was 5.1, then 6.8, which is almost 33%. And take care, that patient was having asymmetry already, asymmetry on their face. Okay.
Now we can officially use those.
Yeah, we have. I'll send you on the group or whatever. We have a clinical paper already described, and you can send it by WhatsApp as a video, or so we measure again the right frontalis as well. It was 1.8 millimeter, then it was 2.2 millimeter, 22 increase also percentage. The left frontalis, that was marvelous because that patient was already suffering from asymmetry. It was 0.8 and then it was 1.6, almost 100% increase in the mass. Now let us see the patient before and after. This patient is a medical rep. Everyone in the market knows her. And now see the depth of the nasolabial fold and the definition of the jawline. See, this has gone. Everyone saying that she has been injected with fillers on the malar fat. Zero injection. Only 4 sessions. So there's another patient actually with the ultrasound, and now we are doing 2 studies. One to prove the concept, minimal amount of filler, maximum lifting. Other study is with the Botox. And the third study, that is one with Tuzian global speaker. It will be something completely different, and I'll keep it surprised. But we are working on 3 studies now. Most likely, the first one will be published by September, end of August. Each study between 10 to 50 patients, so it's not a small study. Now, some before and afters, and we have tons of before and after. What does that mean? That we start to know exactly the treatment is not subjective anymore. I would not come to stand here if the treatment was subjective. We know exactly what's the outcome. There is no subjective. It's always an objective. We know exactly, and you will come to know exactly what's happening. Two, and 1 treatment only in the plasma, but we are working on the plasma a lot, but only in our clinical room in the company, because actually I tell my team not to promote the plasma, fractional plasma, because, and even not to get the handpiece to the demos, to the demo clinics, because once we involved the handpiece, the doctor will say, "What is this? I need to try it." No, doctor, please. No, I need to try it. Doctor, this is plasma, this is need precaution. Oh, I know everything. And then the treatment of the face is perfect. And once he see a small hyperpigmentation, he leave all the treatment. It's hyperpigmented. What's this? So this handpiece is kept in the office. That's my experience, and this is what I'm doing. I focus only on this, and then I push later for this. And this will be an added value, even if I give it for free, but I don't do it because it's really hassle. It's like I'm bringing problems for myself.
This is my question. How many of you sells? Yes, do you hear me? Yes. How many of you sells Jovena because of esteem or because of plasma? This is interesting to know. I mean, because I would like to know if it's because of esteem or is because of plasma or both, but
Yes, Salaman.
fasting, predominant fasting.
Both for us in Spain.
Raise your hands for plasma and the girls, if someone can count from Brera girls.
2 plasma. Plasma roll means.
And for face team,
Fasting also.
Oh, this means that a lot of people are not selling
Saying, no?
because nobody raises hand. That's great. So the question is, would you believe if we exclude the plasma, that would be an issue? Yes or not?
Well, in our market in Spain, the people buy Jovena because they have this plasma roll and the face cream here.
Okay.
But I understand what you said.
Yeah.
Totally right. That in certain doctors, if you get the plasma and they start to get it's exactly what you said.
Yeah.
And then you trash the sale because they go looking for pink or whatever.
Exactly.
Yeah, but
Because
the plasma is an add value or not? I mean,
Yes.
if you go in the market,
I understand.
no, I mean the plasma is an add value, or just if you go like this, you can sell the machine. Huh? Plasma is a problem.
Yes.
Okay.
But it could be an added value once we define a protocol to standardize the output
The combination.
without the combination.
No, I mean also.
Yes, because this is only plasma. And I think Hussein in Spain has an incredible results also for the body with the plasma. So this means it's a big business, but if we launch it as a standalone business or an added value, but an added value, if you have both together, this is the standard value. If we remove one and then add it, it's an added value.
I've already sold one, especially just for the face thing. So we don't be different between other because
Yes.
the doctors can only use the full Jovena, but my physicians can only use the roller and the face thing. So if they are not feeling okay with plasma, we only do at that
Face thing.
face thing.
So you reduce 10,000 from the price and give it without the. Right, we are fair. We accept it.
We can put this on body steam.
Yep, this will be great.
10,000.
Yes, totally.
It's only just to talk. Just to talk.
No, it will be really great.
But not the same price, of course.
10,000 more.
It's not so easy.
Yes.
But do you think we'll kill Jovena or
No!
No, but so what? So what if you kill this with your other competitor? Yeah, it's sure at the end.
Do a Jovena, Plasma Pro, and body skin. And body skin with Jovena.
oh, Jovena like it is? I mean, people that want a full face system is Jovena.
Yes.
Body steam like it is, or let's imagine 10,000 euro more.
Yeah.
Body steam.
He's becoming like me, only 10,000.
If you buy this, 35. If you buy body steam, 38. That's how much is 17 plus.
Or 200, like BTL.
With 48, you have a face steam and body. You have the steam family in one machine.
It's a different thing because in my market, they would never buy the face thing because it's on the body skin.
Yeah, but you still have, no, but you still have Jovena that kills.
So if you choose
No, it's-
this now,
Of course.
you have time for that. If you have time to use it for body stick and you can add the face thing, that would be another value.
No, because for example, Jose has a big problem. He sold how many Imperium?
180.
100
Oh.
Imperium. So he's trying to do the change, how do you say? The renewal plan. So
Yeah,
he went
trade
there
in.
with the body steam, and the customer said, "Okay, I like it, I want, but how can I do the face? Because Imperium was using face and body." They say, "Okay, I want to do it, but give me something for face." So he's facing this problem now that body steam is too much on his only body. So from this, I was thinking. The other is that I'm learning that you're selling more and more only this, and this is an some customer appreciate, others don't care. So they buy because this is the machine, but maybe they use only face steam. Don't forget we have plasmage, yeah.
Ah.
No, I mean we have plasmage. Don't forget people that want plasma, there is plasmage. It's not bad. It's still a valid machine, and the price is good.
See? It's your problem. See where you put the plasmage.
Because it's the thermocontraction now.
Nah.
Because the focus is the thermocontraction.
Having a steady family grow or something, have the face applicator, it is more expensive. There are clinics that the space to having two machines that they might want to do face and body. You know,
Okay, yeah. Good to know.
Good. We have also tried with male, and this is one session only. So here I ask you to have attention to the nasolabial fold. This is 30 minutes after the treatment. But again, we are not using thermal, so this is not edema. This is not edema, this is no swelling, and this is, we call it end positive point. So that, one session, yes. Yeah, one session. All the result, all the picture that I'm showing is one result, except of that, of the study. I will, yeah, I will show you. I'll show you. Yes, sure. There is some picture I can show you on my phone because it's in the study, and most of these pictures, take care. It's some pictures I will let you know that it's in the study, so don't share it. Otherwise, it will not be published. Okay. This patient has also an asymmetry already here, and this you can the depth of the nasolabial fold and the length of the nasolabial fold. So see, length and depth. Length, depth. One session. And still even the mark of half and half is there. Also, one session. Zero thermal. We don't use thermal. Because I don't want someone to come, this is edema or this is swelling. Or, okay? This, please don't take a picture of this. This is a VIP patient. For CrossFit, don't take pictures or you'll be fired. This is the grandmother of Minister of Interior in Kuwait. Okay. Yes, please. Okay. She's the same. See the lines here and the lines here. Okay. One session. Okay. This, she is an immunologist doctor. After COVID, she stopped responding to Botox. My client. So, and we challenged the doctor to see the result. So, this is the result. Okay? 30 minutes. Yes, this before, this is 30 minutes after. There's no heat. Actually, in the front, in the forehead, there is nothing to heat. And this is when she frowned. So this is in the front, and then this she when she raised. It's a Botox effect. Yes, this will be the question to be answered during the treatment, the live demo. We will go through it in details, the protocol and the expectation, because we don't want to ruin our business by. Exactly. Okay. I'll show you myself. Okay. 1 year before and now, I'm alive in front of your eyes. But this, let's say like this: the patient do the treatment in the baseline, in the zero today. 3-4 days for the forehead. In 2 hours, the treatment will be much improved, and you will see this as a video. In 3-4 days, for the frontalis, it takes 7 to 10 days. The treatment are perfect. It's like a mirror, okay? No, 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 no. You see the results off table immediately, but especially for the mimetic muscle within 2 hours, because the muscle start to rest more and the effect will be much better in 2 hours. Okay, this is why I'm telling always this, because we cannot wait for 2 hours to have the picture. Wait it only for 30 minutes. But for the frontalis, for the forehead, the result lasts perfectly 7 to 10 days and then start to fade. But is not fading to the baseline. It's like 10-15%. But the patient tell, the result is fading away because he is comparing not the zero, not the baseline, he's comparing post. That's why we say the second session is mandatory to be within a week or 10 days. So we don't let the patient feel the collapse. After the second session, 70% of the initial treat result is there. And the last two is almost to improve and to maintain. I will show you in depth. Okay. This is another patient. So this treatment, what we are calling Botox booster. But again, as my advice during the call, don't go through it because you will find a lot of struggle and hassle again as a doctor. But if we are going to the doctor with a proper call for the frontalis, we beat the doctors. All of them, they are super convinced. But it's a different way to express your call and need some experience. So instead of putting yourself in that position, so the doctor start to forget about the mid face and he only catch you because you say that blah, 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 blah. Focus on where like the blue ocean where there is no competitor. And then during the treatment, do the frontalis. So seeing is believing. This aesthetic lines, very deep. This is 2 sessions. Okay. Okay. Jawline. Can you see the difference? Is there any difference? Okay. Okay. 1 session. Yeah. Yep. This, yes. We don't target the spatisma, but because of the jawline lifted, yes, and the razor, yes. So imagine.
1 session, right?
Yeah, 1 session. Lifted liposuction. Yeah, this actually patient was in Dubai, treated last week, and tomorrow she's going to have the second session. So actually, imagine here you have a muscle called masseters. So when it pull, it will have the effect till here, and this is exactly what you can see. Here you have the rhizorius. Remember? Shall I get it back? Huh?
Very far back.
It's okay, huh? Clear? Okay. So the rhizorius, when it's being strengthened, it will lift this. Good. Periocularis. This is no plasma. This is only the contraction without thermal effect. Crow's feet. And see, again, we keep repeating because now the treatment is objective, is not subjective. We know what we are expecting and we know what we are treating. So I'm keep repeating the same thing. Cross feet, I know how to treat it. Nasolabial, jawline. So it's more defined protocol. Okay, so.
On those, are you doing frequency with RA?
To be honest, it's a 2 minute which has no clinical value just to get the patient into mood and to let the doctor knows that there is heat. We can produce heat and we can switch it off. But it has no clinical value because the heat is not reaching to the muscle, or if you heat up the muscle, it has nothing to do with the business. The heat is only for the derms, collagen, elastin, and blah, blah, blah. So now we have, let's say, an improved scientific call. We have a super interesting topic. Believe me, it's a super interesting topic whatsoever. Plastic surgeon, neurosurgeon, dermatologist. If you start to talk about the deep tissue structure restoration, elevator muscle, depressor muscle, how this do, how you involve the filler, what's the limitation nowadays of filler injections in order to induce the lifting. Any doctor would love to be a KOL for such technology or for such topic, let's say, because it's super interesting topic, and I guarantee you, no one can go through this call except us, all of us. Sure, guaranteed, unless spies. So this means that we can go to any KOL with muscles. We can go bold. We have something that feed your ego. You will be the first one to introduce blah, 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 blah. You are the first one to speak about this topic in a local congress or in an international congress or a regional congress. We have the clinical evidence supported with ultrasound and soon will be published studies. And we have been working. Let me share with you one big mistake that is truly affecting us. We started, as I mentioned, early 23, once we received the devices. We started with Kuwait and Egypt in parallel. So at the beginning, we were exploring the device and selling it for fractional plasma, blah, 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 this and that. And then we improved to have come to, let's say, focus on that claims and elevator and depressor and all of that science. So we start to go to the doctor with the same device, but with a different call. Then, yeah, they know us very well, they trust us, so it was good. Once we improve more and more the protocol and we know the expectation, for the third time, we went to the same doctors, same device, a third time call. At that time, it was spectacular, little bit. Okay, it seemed that what you're doing there, only because the results was really improving with each call, we were gone. Our reputation would be gone unless the doctor really trusts us and they give us the chance to prove. This is why we have been working the last year to develop a key opinion leaders. Unfortunately, whomever, what level of experience, if he is not an MD, medical doctor, he will not be able to teach doctor in a globe. I mean, doctors always listen from me. If 1, 2, 3 doctors on a dinner, they always listen from me and they ask and they learn and we learn from each other actually. But in a lecture room, front of many audience, it will never happen. So unfortunately, we need a doctor, even though we are telling him what to do, and even though we are preparing him the presentations and everything, but we need a medical doctor. So once we recognize the value of this, we start to build a network of key opinion leader. And for the moment, we have a key opinion leader who's global speaker for MERS and Aptos. She's Dr. Amira Taous. She was an MCAS having a workshop on the Jovena. We have a KOL who is a global trainer for Tuzian filler, Tuzial before. And we have a regional trainer for Sinclair on board. These 3 doctors are well known not only in the Middle East region, but they are well known in Eastern Europe. One of them, Dr. Shadi, the one for Tuzial, is well known as well in the States. So feel free to use them at the beginning if you would like to have a symposium, a local exhibition, something like this, that we can use these guys. And they are very strong in knowledge and they know filler very well and they're well known. So when they combine filler with the Jovena, people start to appreciate. And the most important, we have a high demanded application. Everybody, it's facelift is the main indication nowadays. And we have the teamwork. And that was the reason behind this meeting. We need all to create the global momentum, to unify our call, unify our claims, use the same message, use the same videos, marketing materials. In UK, even we have used actually the what was Link Helton? What was the name of that lady? Nikki Helton. We use that. We also in our region, we are spending a lot on creating the noise, and this is what I would like to share with you. So what we need to do now is really to create the noise. But if you're creating the noise and she's creating the noise and he's creating the noise and we are creating the noise, it will be a big boom. Everybody is speaking about the same concept. It will be a trend. So searching Instagram, Jovena, boom, a lot of celebrities. Searching Google, Jovena, celebrities. This is what really need to know that we have to do. Otherwise, we'll keep being humble. We sell what we can to sell till another competitor will come, burn some cash, and get our efforts. Because we will not enjoy the exclusivity forever. I don't mean exclusivity from Brera. I mean Brera will not enjoy the exclusivity of this call or of the bio or the myostimulated pulse. It will be copied and it will be ruined.
Totally agree with you. I think it'd be a really good idea if let's essentially there, we will share our social media handles to various outlets.
Yep.
It's center around and we can all to each other.
Exactly. Especially that celebrity start to be celebrity everywhere. Like a Middle East singer, he got 2 Melody Star award, and he's well known in Europe. He's well known in the States. Maybe he's not well known for somebody. Maybe let's say I'm not familiar with Taylor Swift. Let's say for an example, but this does not mean that my colleagues or other group of patients they are not familiar. So celebrities start to be celebrities everywhere, and thanks to the social media.
Now, it's really interesting because when there was this first singer that we treated, I didn't know her on Instagram. She had like 5
Yes,
followers.
Radwa Sherbini.
But then I shared it with my distributors, and Christian from Germany
Mhm.
published it as well, and he got an incoming call from an Arabic doctor practicing in Germany.
And one so interesting story. In Lebanon, there is one lady. She's married to a Brazilian doctor in Lebanon. She called our UE office to investigate about Jovena in Lebanon. It's far, but it's happening, and it's always like this. Tina, how many leads start to send you request about Jovena? It was not there, but it has been generated because of the noise. So we really need to gather to create the noise and the momentum. Same call, same marketing, same videos concept, and we will go through it. And honestly, we have to use each other efforts. So let's say I know that Marta from UK is participating in FACE, okay, in FACES. A lot of people from the Middle East going to the FACES. So I call Martin. I'm coming with 2, 3, 5 doctors. What scientific symposium or lecture are you having for Jovena? He say me, okay, I have this workshop. Bring your doctor. My doctor, when they go to the UK and find UK British doctors using Jovena, they will get confidence, right? When they go to Germany, it's the same. When they go whatever. So when doctors find that this is popular treatment, they gain confidence. And then only we can sell more expensive because it's a trendy. So rather than keeping digging in the rocks, no, we dig with the big hammer because it is our hammer we created, right? But it's not really, it's not good that my doctors, because you know, in the Middle East, they love to go to Europe. And I know in Europe, they love to come to Dubai. So imagine, European doctor, you try your best to introduce Jovena with all of the science fiction, blah, blah, blah. And they come to Dubai Derma or to Midan. Where is Jovena? I cannot find Jovena. What's that? This means that Jovena is hiding. But if they go to exhibit to Dubai Derma, find Jovena. If they go to IMCAS, they find Jovena. If they go Faces, they find Jovena. With support of lectures, workshops. This means we are not anymore a small acting or acting like a shine company. We have to be bold. So for this, I'm inviting all of you There is the one Congress, it will be held in Cairo. But why I'm telling you this, not because it be held in Egypt and you go out to have fun, because the weight of the scientific program. You know, who's selling fillers? Good. You know Professor Sebastian Cotofana? Okay. Cotofana is like the godfather of the anatomy. Okay. Cotofana is only practicing in US, is only attending or making classes in US, but Cotofana is something, doctor, you know him, huh? Something big. Huh? The only Congress outside Europe or state, Cotofana is practicing is in the ICC. And this is. Can you raise the.
Based in the United States. And I'm actually really looking forward to the upcoming edition of the ICCE meeting, which will take place in September in Cairo in Egypt, because during that meeting, there will be live injections and live anatomy demonstrations on stage for the entire audience. So the injector will treat the respective region, and I will show what is located under skin, because normally injectors, unless they perform the respective surgery, injectors, they cannot look under the skin. But with live anatomic dissections, we can relate where the product is going and how the underlying anatomy looks like, and if there are any danger zones in that respective area. So I'm looking forward to seeing you there. It's the Anatomy Masterclass
So,
during this year's edition of the ICC.
what I mean, in this
Date is
Congress,
September 2024.
Professor Kutufana is going to be there. So it's a very big attractive point. But what is the benefit out from this? There in the Congress, we are going to have a full booked room for us. We're doing a lot of Jovena treatment that will cover 3 topics. First, how to use Jovena to treat Botox complication like droopy eye. If a junior doctor injecting Botox too much, shit, I injected a lot and I got a droopy eye, what to do? You treat Jovena. It's a different protocol. Another session, Jovena in a supported or in a combination with filler. So we get the patient half, inject, do Jovena in one part. This is live, and will not do Jovena on the second part. And then we inject half cc here, half cc there, and you see the result. It's a mind-blowing. Third session, Jovena alone. And on the mainstream, the device will be there on the mainstream, the main lecture. So it's not only, actually, the last year, there was 7,000 attendees. 35% was from Europe, 17% US, and the rest from the Middle East. But why? If you send this Kutufana video to your doctor, even if you're not selling filler, but you tell the doctor, if we have a deal, if we are going to close the contract, I sponsor you to attend this Congress, and you have a great entertainment effect. Then we can go to Sharm el-Sheikh. We can arrange this for Brera. We can have a boat with a barbecue, the scuba diving in Sharm el-Sheikh, and I'm sure Europe will love to do this, right? Okay, but this is not the only attractive point. Yep. Yes. See, we have done this. It's a deal. I have let's say I have 3 pending deals only on the last. You go with the new message, and doctor, we have a good offer to you. It's coming from Brera. We have a big event that Dr. Kotofana will be there, and the Queen of Lips. You know her? You know her? You know her, Queen of Lips. You know her? Exactly. She's not easy to move out from the States. And so if you start to sell this to your doctor, not to sell the Congress, sell the device, and complimentary you will go to the Congress, not a cheap Congress. By the way, it's twice the space of Dubai Derma if you have been there. Okay, and there, Jovena will be in a very prestigious booth, 8 by 9 meters, almost 72 square meter. But not only this, the most important is the entertainment. Life on the pyramids. Life, can you increase? This is life on the pyramid. And this is the singer who took 2 Melody Star Awards. And this will be exclusive for the doctors. Let's spend the burn cash, huh? Money talks.
خير جميعا في حفل ختام المؤتمر الدولي للتجميل ICCE 2023 في نسخته الثامنة.
ICCE is one of the biggest conferences all over the world, with speakers from more than 30 countries and 7,000 attendees from all over the world.
احنا فعلا مبسوطين ان احنا بنقدم لكم international quality على ارض مصرية.
Actually, this event was, this is the Tizian speaker. This is what Doctor love. Out of mood. And I'm telling you, we can arrange a specific event post the Congress to Sharm el-Sheikh, where we can have an exclusive event for Brera users. We've done it before with Quanta, actually. We have got the big yacht with a barbecue, scuba diving. At the evening, we do like a Sahara and Bedouin party. It's something like another level. And then only we act as big, a muscular company. These are the list of all the speakers, and there is more. It's becoming more international. And again, we are not selling the Congress or the workshop. We are selling the idea. If the doctor come to such, let's say, Juliana, when she comes, she's from state. She's not practicing the Middle East. But when she come, and you find one of your customers attending the same Congress, giving the same lecture of Jovena, she will start to talk. And then it will be much easier for you because it's not anymore a shy device. And what's next? Not now, but you look forward to very shortly, vaginal stem. Nope, no. that will target. It will target the urinary incontinence, and the intimate enhancement. Okay? Now it's the time for the live treatment. Any question? Good? The